Hey guys, thanks so much for working with me. Since I won't be in class coming up. Um, so here is this recorded video lecture for respiratory 2160. Whole class number 6 is mostly just for me to kind of have things organized and figured out. We're only covering a couple subjects because it's um, just one class we're going to have covered, but we can work on getting other classes recorded if we want. Um, just a little asterisk. It should be quiet. We shouldn't have a ton of background noise, but if you do hear snoring, it's because I do have Artie asleep right next to me. So sorry about that, but hopefully she doesn't snore. All right, so what we are going to talk about in this specific lecture is ABG analysis and some tests to go about in it. Ventilator parameter changes you would make with an ABG. So if you are presented an ABG, it's out of range what you would do with the ventilator, what changes you would make. Also different patient conditions. So if your patient is presenting a certain way and you're wondering what to do, what ventilator changes you would make and what parameter changes. How to deliver different medications in the line invasively on a ventilator. And we'll also review it a little bit with non-invasive as well. We'll just briefly touch on that. Ventilator alarms and then trigger sensitivity. These are what we will review in this specific lecture. Sorry, I had to adjust my computer. All right, ABG analysis. So arterial blood gases are kind of, when it comes to any type of lab draw, any type of lab analysis, are our little bread and butter. And that's because it has to deal with the three major organs that are our little bread and butter. This has to do with the relationship of the lungs, the hearts, and the kidneys. These three organs are kind of the little three best friends that troll around the body. All of our organs like to hang out in homeostasis, but if the heart, the lungs, or the kidneys are out of balance, then they're kind of like the plastics in Mean Girls. They're all kind of off, and they're all having drama and trauma. So that's why they try to compensate for each other. When one is off, the other two attempt to compensate and keep the body stable. So if one of the plastics is having a bad day, they try to help the other help out. So this is repeated content, but we're still going to review it. In the little packets I gave you, I also have this in Canvas in that little module at the bottom of our Canvas home screen. But this is basically a repeat of information I've already given you, but we're going to go through it just because I do think it is good information. And in your career as a respiratory therapist, it's also information you're going to be reviewing and doing every single day of your life when you make it to the ICUs. Literally every single day of your life. You are going to live, laugh, love these values. So pH. Remember, when you are sitting for your board exams, they deal in absolutes. So pH. This is the number of hydrogen ions located in the body for our acid-base balance. So essentially that's just how acidic or alkalotic the body is. So we want to maintain it normally. The range, 735 to 745. We want to try to keep it within there. In the hospital setting, that's pretty average too. We want 740, beautiful. That is where we shoot for. When we start talking calculations for trying to keep it in that normal range, that's where we want to try to keep it, 740. When I'm trying, and we'll talk about this with the ventilators also, when I'm trying to shoot for a range, because we have science, but no ventilator management is exact science. So when I'm trying to guess the best place to get my ventilator where I want it to be, I shoot for a middle range, and then that should get me pretty dang close. So if I'm trying to shoot for a middle range, like I'll shoot for 740 because that's the middle of 735, 745. So if I end up 742, we're still pretty happy with that. So just kind of keep that in mind as I'm lecturing about ABG analysis. So, sorry, that was a little bit of a tangent getting ahead of myself. So the lower the pH, the more acidotic we are. The closer to 7.40, the more we're in a perfect state of homeostasis, the more normalized or more compensated we are. The higher our pH, the more alkalotic we are. And again, we're trying to keep it where we want to be. The visual I like, you guys know me in analogies. I like to think of blood gas analysis as we're on a teeter-totter, and pH is the middle of the teeter-totter, and you're trying to kind of balance out the teeter-totter, or you're on a scale, and pH is on the teeter-totter, and you're trying to kind of even out your CO2 and your bicarb to try to make the teeter-totter or the scale even out, so that we're in that perfect 740 range. Okay. Moving down, CO2 is the level of CO2 molecules in the blood. This is directly related to ventilation. So the range, again, dealing in absolutes per the NBRC, NBRC deals with, and our board exams deal with absolutes 735, 745. Hospital can be every shade of gray. So the lower the CO2, the more alkalotic our patient is because they are overventilating. So that's what I have here. So our CO2, they're hyperventilating, they're breathing really fast, they're blowing that CO2 down. So they're getting more alkalotic because they're blowing that CO2 down because they're overventilating. 40 is where we're trying to shoot for, which is normal, which is ideal. If we are underventilating, we are in an acidosis because we're underventilating. So that CO2 is continuing to climb in the blood. So we're not ventilating, maybe they're apneic or they're really sick and that CO2 is continuing to climb in the blood. And so that CO2 is starting to climb and we're becoming acidotic because CO2 molecules cause acidosis. Oh, didn't mean to do that. Sorry. Back it up. Okay. Jumping down to PaO2, which seems like a weird thing to bring PaO2 in, but that's because that's how blood gases are read and ran. So that's why I want it to be kind of normal for you guys to see, like, why don't we just put bicarb and then PaO2 when we're talking about it? But that's because that's how blood gases are ran. That's a good question for a lab person, not me. But that's how they run it, and so that I put it in this order specifically just so you guys can get used to seeing how it's ran. That's the order it's placed, and that's the order you will see it when it's presented and printed on a blood gas. So a PaO2 is the partial pressure of oxygen molecules in the blood. So I want you guys to notice partial pressure of oxygen molecules in the blood. So again, 80 to 100, hard, fast rule on your board exams. Remember, your board exams are written for people at sea level. I know I'm posting this on YouTube, and I have a couple people that like aren't in Utah with us, but I literally work in a hospital built on the side of a freaking mountain, and that's very much not on sea level. Um, so I quite frankly am happy with anything above 60 for my PaO2s because I'm at a high altitude and I don't have that partial pressure because my barometric pressure is quite a bit less on my PaO2s. And someone that's lived in Utah their entire life, they've acclimated and they're used to that. That's normal for them to have a slightly lower PaO2. And 60s, I'm starting to get a little bit stressed and I'm going to keep a close eye on it. I prefer 70s or higher, but 60s are just kind of like, okay, I'm getting a little wary, but I will accept it. It's like a solid like C plus where you're like, I will accept this, but I don't like it. But on your board exams, everything's meant to be at sea level, 80 to 100. So anything less than 80 is considered hypoxic, and you need to either increase your FiO2 or increase your PEEP or your CPAP. Anything above 100 is considered hyperoxia. You need to decrease your FiO2 or decrease your PEEP. And then bicarb. So this is the metabolic. So this is your kidney port. So pH, overall body acid-base balance. This is the whole picture. CO2, lungs. PaO2, heart and lungs. And then bicarb is your kidneys. They're our metabolic status. So these are your kidneys doing your acid-base balance. This is, again, controlled and produced by the kidneys. The range is 22 to 26 milliequivalents per liter. Anything less, so where the higher the CO2 caused acidosis, the higher the bicarb causes alkalosis. So CO2 and bicarb are kind of the anti-versions of each other, if that helps. They're the opposites of each other. That's where the teeter-totter comes in. They balance each other out. So, and that will come in with our interpretation coming up on the next slide. Because if the higher the bicarb, the more alkalotic a patient will be. The lower the bicarb, the more acidotic a patient will be. And that'll make more sense on our next slide, so that's what I'm going to move to. Okay. That goes with categorizing and interpreting our ABG. And I know you guys have done this before, but we're gonna go through it again because repetition. So categorizing, we either have a completely normal, perfect, beautiful blood gas where everything is in range, everything is perfect, and it's gorgeous, and we love it. Cool. If they're sick in the hospital, that's weird. I didn't know those existed. If we're in the ICU on a ventilator, that's weird. That's very rare. Fully compensated would be if the pH has been fixed. So fully compensated means the pH is corrected, whether it be by the CO2, the bicarb, or both. Okay, so I'll say that again. Fully compensated is the pH is now normal or within range by the CO2, the bicarb, or both. Partially compensated is the pH is starting to get into range by either the CO2 or the bicarb, but it's kind of like it's working on it. It's working its way there. Uncompensated, and I have examples also. We're going to work through some of these, is basically like our patient's broken. We're broken. Either CO2 or bicarb's off, and one or the other's completely off, and our patient is sick, and we need to fix it, and we need to intervene. Whether our CO2 is really, really high or really, really low, or our bicarb is really, really high or really, really low, and it's throwing our acid-base balance off, and our patient is really, really sick, and we either need to give some type of medication to help our metabolic status, or we need to provide respiratory support to support our patient. One or the other. We need to intervene if we have an uncompensated situation. And a combined is both are broken. So basically, CO2 is off and the bicarb is off, and this can often happen in diabetic ketoacidosis, where the bicarb is in the toilet, and so the bicarb can be something ridiculously low, like 6, because the blood sugar is insanely high. And because the patient is extremely acidotic, because the bicarb's in the toilet from the blood sugar, the patient is hyperventilating like crazy, trying to blow off CO2, trying to normalize their pH. So then their CO2 is like 12. So trying to normalize, but their pH is still very acidotic due to their metabolic status. So there's not much you can do as a respiratory therapist besides you might be called to run the blood gas and just be on standby in case the patient does need something. But that would be considered a combined metabolic acidosis, or else an uncompensated metabolic acidosis. So there are some situations such as that. I remember being a student and being very overwhelmed with ABGs and looking at it and be like, okay, so you give me this blood gas, but like, where do I even start? Like, you just threw some numbers at me and you want me to categorize it, but now what do I do? So I like steps to kind of have a strategy to look at. So first I look at the pH. What status am I in? Am I normal or fully compensated? So am I within range? Am I in my 735 or 745? Okay. So that tells me I am either in a normal range and I'm okay, or else I have been fully compensated. Okay? I'm one or the other. If I'm not that, then I'm out of range. So if I'm with that I identify, okay, so am I acidotic or am I alkalotic? Okay, what's our issue? So then that lets me know, okay, I identify I'm either acidotic or I'm alkalotic. Okay, noted. With that, I'll have to know whether I am uncompensated or partially compensated, but we'll put that in our pocket for the end. But I do know I am one or the other. Okay. Next, I will look at my CO2. With that, that lets us know our ventilatory status. Part of it, not only because we're respiratory therapists and lungs and breathing, and we can intervene there, but also CO2 allows us to make quick changes to the acid-base balance, where with metabolic, it takes a little bit of time. It takes the body time to work on that metabolic status change. Where CO2, we can make pretty big changes in a matter of minutes to a ventilatory status. So now that I have looked at my pH and I've identified whether I'm acidic, normal, or alkalotic, I look at my CO2. Am I high? Am I low? Or am I within range? And that lets me know partly whether I need to consider intervention or not. Okay. And then that brings me to my next step of bicarb, my metabolic status, and its relation to my CO2. Back to this is a slow fix. Because say I have a high CO2 but a normal bicarb, then I know that this is an acute respiratory situation. But if I have a high bicarb and a high CO2, I might thinking this might be a more chronic situation. So always note your bicarb in relation to your patient's condition. Bicarb gives you, this is a big asterisk and a big red flag with bicarb. Bicarb will always give you an indication whether it is an acute or a chronic condition you're dealing with. It will give you a good little heads up. So that will be to note. So next we're gonna come on down to some ABG examples we're gonna discuss. So we're gonna start 1, 2, 3, and 4. So the first one here. So from here on out, when I write blood gases for us to work through as a class, when I write them, and you guys are like, you just wrote a jumble of numbers. So this will be pH CO2 / PaO2 / bicarb. And that's commonly what you'll see in like report. And a lot of RTs will write it similar, maybe not exactly, but a similar way like this, like in a report or when talking to a doctor or reporting a critical or something like this. This is a common, but maybe not always set up that you will see. So this first one, okay, let's look at our pH. We have a 722 pH. All right, so we know we are acidotic. Okay. We are acidotic. That means either we are having a high CO2 or we are having a low bicarb issue. Let's take a look. Okay, our CO2 is 82. All right. We have a high CO2, which means our respiratory status is not great. We are not ventilating. So any type of high CO2 would mean we are not ventilating. And then we're just going to jump over to our bicarb and we'll come back to our PaO2 to 24. Okay, that is considered normal. So our bicarb is normal, so we're going to call this an acute condition. Okay, so this would be an uncompensated because we are not fixed. Respiratory because it is a CO2 with our metabolic, it is unaffected. Acidosis, and with a low PaO2 on our arterial blood gas. So this would be a hypoxic, uncompensated respiratory acidosis. This patient would need respiratory intervention. Most likely either per the NBRC, they would say intubation ventilation, or else per clinical judgment, you could even consider non-invasive ventilation depending on what's going on. I literally just made these ABGs up, so yeah. That's that blood gas. Moving on to the next one. Let's look at our pH. 7.39. Beautiful. It's right where we want it. It's right close. It's right close to 740. I love it. All right, 62. That's kind of a high CO2, but there's some respiratory issues going on. But this is normal. So are we compensated? What's going on here? Let's take a little gander. So we go over to our bicarb. Oh, our bicarb's out of range. But it's high. But my CO2 is also high. So because my CO2 is high, because my body doesn't like how high my CO2 has been for a while, my kidneys made more bicarb to kind of even out the high CO2s. And because bicarb is alkalotic, it kind of evened it out. So I have a fully compensated respiratory acidosis. So odds are this patient has a chronic condition causing high CO2 retention. So this patient could be COPD, they could be a COVID long hauler even, they could have they could even be a sleep apnea patient, certain with really extreme sleep apnea. They could be a whole bunch of different things. Extremely bad asthma, smoking, anything like that. And then we'll look at the oxygenation, and oxygen is ideal for whatever mode they're on. So this would be a fully compensated respiratory acidosis. Or with a chronic CO2 retainer. Okay. All right, moving over to this one. This one. Uh-oh. That pH doesn't look good. 7.12. We're real acidotic. Okay, so we're acidotic. Uh-oh, but we have a really low CO2. That doesn't look good. Jumping over, sorry. Over to our bicarb. That doesn't look good either. Okay, so what's happening here? This one's a little tricky because it's one we don't commonly talk about because we talk a lot about ventilators. This is, brushed on it a little bit on the last slide. This was a common one you'll see in diabetic ketoacidosis patients. So, you'll get diabetic ketoacidosis patients, where they'll come in, it'll kind of have like a weird, like, fruity body smell in their room. They're always like very sweet, but they're also like exhausted when they come in. And their blood sugar will be through the roof, and their bicarb will be super low because their blood sugar is crazy high. And to compensate for this insanely low bicarb, because their body's trying to regulate their metabolic status, they'll be breathing as fast as they can to try to get this pH where it wants to be, because their body's trying to compensate. Their brainstem's working just fine. And there's not much you can do as the RT except notify her the results. And if this was low, you could give oxygen, but that's a beautiful PaO2. But a lot of times it just takes insulin treatment and some other medications. But if you see a blood gas like this, a lot of times it's a metabolic condition. But just be aware, you might see blood gases like this. That's why I put it on here. All right, moving to this last one. 7.41. Oh, that's beautiful. Oh, that's nice. 36. That's pretty too. 25. Wait a minute, this one's looking a little too pretty. PaO2 of 90. Wait a minute. Yeah, I put a normal blood gas because sometimes I feel like boards will just like throw a normal one at you and then you feel like you did something wrong. So I threw a normal one on because literally I was like, I got a normal one on my boards and I literally sat and like second guessed myself for like 10 minutes. I was like, what did I do wrong? What did I do wrong? So this is just a couple examples. We'll work on giving you guys more ABGs to kind of work on changing your patient's condition and ventilation. And then I do have in your little packets I gave you this information also. CO2 changes. So this is adjusting CO2 with your ventilator. So like if we had gotten these blood gases, kind of what you would change with your settings, with the initial settings we would have. This one's CO2, the next slide is oxygen. I have little calculations, again in your little packet, I have calculations because I know students love calculations and you do need to learn the calculations as well. But again, I don't want to, I'm spoon feeding you because I feel like feeding you with a garden hose is really, really mean. And so we will do more math in the future, I promise. But yeah, I don't want to do all of it in one day because that's a lot. Because mechanical ventilation can be a lot. So these are the rule of thumbs, both for changing what changes to make for CO2 changes. And these can be either for hyper or hypoventilation. So if you have too high a CO2 or too low CO2, so this can go one way or the other. So if you're, again, your board exams, absolutes. So if your CO2 is 46, your board exams consider that as not ventilating. Where like, if I was working and my CO2 is 46, I'd be like, right on. We're looking okay. Sounds good. Especially if I had an insanely sick patient. I'd be like, sounds good. I love it. So again, absolutes. So if you get a blood gas for your patient and your CO2 is 1 to 2 off, your board exams want you to change dead space ventilation, which is just extra tubing on your circuit that is just hanging out in your circuit, not really doing anything additional flow. We don't really do that in the real life because we try to prevent breaking the circuit, and that's just kind of a weird thing to do, like, and really wouldn't change your CO2 much enough in the real life. But powers that be at the NBRC want you to do that. So do that on your test. I'm sorry. Whatever. I don't make those rules. Love you. If you are anywhere between 1 to 10, above or below on your CO2, increase or decrease your tidal volume. And again, we will do those calculations. You can start looking at those calculations if you want and start kind of playing with them. That's totally appropriate. But you will increase or decrease your tidal volume. An analogy I like to use is big bites and little bites when it comes to changing CO2. So, like if I have a blood gas and I need to make large changes, I like to call them big bites. But if I just am fine-tuning or making smaller changes, I call them little bites or little nibbles. So I like to think with my tidal volume, these are for my smaller changes. They're my little bites or my little nibbles changes to my blood gas. Think of it as that. My tidal volume, they're my little bites. Whereas respiratory rate, this would be if I need to make changes either with hyper or hypoventilation of 10 or greater, above or below. So these are my big bites in my CO2 changes. So that's kind of where you would go for the, like, if I got a blood gas and my CO2 is in the 70s, I would go to a respiratory rate. Whereas if my blood gas was 48, I'd end up going to tidal volume. Because that would be in the 1 to 10 range for tidal volume if the CO2 of 48 were in the 70s, that would be 10 plus. Okay, ventilator changes oxygen. Okay, I just feel like it's a lot of rules to remember, but 100% FiO2 for any emergency situation. You know what, that's just across the board respiratory care, any and always, and you're not going to hurt an adult or really anyone by... I've never ever had a doctor be like, we finished up a code and we got a blood gas to see our lactate or anything, and be like, you know, Allie, I know we just finished this resuscitation, but you really, really shouldn't have given as much oxygen as you did. Never, never. So just give them the oxygen. On your boards, shoot to match the previous modality. I like to go a little bit higher just because why not? And then wean down. So while you are on the ventilator, if you are on the vent and you're starting to have increased oxygen needs, so per Lindsay Jones, so you increase your FiO2 up to 60%, and after that you increase your pressures by increasing your PEEP or your EPAP or your CPAP. And then weaning down, you decrease your FiO2 down to 60%. I also like to go a little bit lower because around 40-ish you can support your patient on a nasal cannula, and then work on decreasing your PEEP. For me, a good mental red flag with my practice is if my patient has an increase FiO2 of 20% or greater, or is at 60% or greater, I need to check if I need to work on increasing my pressures, or if there has been a change in condition for my patient. Has my patient randomly popped a pneumo? Has my pulmonary compliance changed? Is my patient getting sick? Like, do we randomly have some pneumonia starting? Like, what's going on? Like, why is my patient having increased oxygen needs all of a sudden? That's a red flag for me, is that increase of 20, or if all of a sudden we're up to 60%. That's when I start getting alarm sirens. And then when I'm weaning, decrease your drug, your FiO2, because your oxygen is considered a drug, before you decrease your therapy, which is your pressure. Pressure, PEEP, any of that is considered a therapy. So decrease your drug before you decrease your therapy. And then just some other little tips and tricks. Ventilation. If you are having a harder time with CO2 management, little longer exhalation time. Just a nice little exhale. Let them fully get that exhalation out, especially if they are obstructing. Also, sometimes the use of a little extra bronchodilator, which on the next slide we're going to talk about inline medication delivery. Sometimes just opening up and decreasing that airway resistance helps them just get all that extra air out to help really get that exhalation out. Sedation is our friend. So I say work with your nurse. So a lot of times if I have a patient that we're really struggling with the vent, the nurse and I just chit chat about like sedation goals, and I'm like, so do you know what like the sedation plan is? So I kind of know what to plan with my vent. If I can if like, are you planning on having them being pretty quiet tonight, meaning they're going to give lots of sedation, or are we going to try to wake them up through the night, which to me would indicate I need to start switching over to a pressure support so they can start breathing more on their own, which would mean more ventilator synchrony. So I just chit chat with my nurse because they're my teammate at the bedside and ask them kind of what the sedation plan is. If they're planning on trying to wake him up more, I try to move towards a more spontaneous mode of ventilation where if they're like, oh, they're going for surgery in the morning or they have a procedure in the morning and their blood pressures have been a little bit of everywhere, they're hoping on just keeping them pretty sedated and quiet tonight. I'll just be like, okay, great. We're just gonna keep them on a control mode and let them rest tonight. Sounds great. Whereas if it's like they want them extubated as soon as possible, I'm like, let's do this. Wake them up. Let's wake them up, get them on pressure support, and get them extubated. So talk with your team, and that helps a lot with ventilator synchrony and appropriate ventilation. Do your calculations. Look at that calculation sheet. But also trust yourself. There have been times I've done the calculation and I've gotten wonky numbers. Like, I've gotten respiratory rates that are like 8, and I'm like, I don't trust that. So, like, even with this class and your experiences and stuff, and yeah, no matter how much math and everything, you're still the one looking at your patient, and you're the one caring for your patient and wanting to do the best for your patient when it all comes down to it. You're still the human, and like no robot or anything could do what we do. Oxygenation, longer inhalation, because longer pressures, it helps give us more surface area, higher pressures, longer inhalation time, and it also aids in alveolar recruitment. So a little bit longer breath. It's just like why we sigh sometimes, because sometimes you just need that big deep breath. Finding ideal or optimal PEEP, which is the highest PEEP we can give without causing baro or volume trauma, and also without causing any blood pressure complications. And then one of the things that I have learned at the bedside, some other tips and tricks, is I always keep, so you will always keep resuscitation equipment, so an ambu bag or whatever your facilities that you'll work at the bedside. So like ambu bag if you're in an adult ICU. You'll have a PEEP valve on it. Make sure that PEEP valve is set to the same PEEP as what you're using on your ventilator. So if it's just like maybe an overdose or a post-op patient or something, and it's set at 5, that's totally appropriate. But if you have an insanely sick ARDS patient, or maybe a COVID pneumonia, or something like that where they're really, really sick, make sure that that PEEP valve is set to the same PEEP that you're using. Because I've been in situations where you go to grab the bag because they're de-recruiting or they're just not doing as well, and you go to bag and the PEEP is set lower than what you've had them on the vent, and they de-recruit, and it takes a while to re-recruit them. So that's just a little like working at the bedside little life hack I'm sharing with you guys. So I do that in newborn and I do that on the adult side. So that's just a little from me to you. Down to the next one. All right, next we're going to talk about is inline medication delivery. We're going to talk about inline MDI, inline SVN, and Aerogen. So up here is our inline MDI. It's kind of nice. So it goes in on the inhalation limb, of course. If you put any of these on the expiratory limb, your patient's not going to get anything. They're going to exhale it and it's going to go straight into the ventilator. Cool. So what's kind of nice is this spacer, this little kind of spirally part, it spreads out and collapses, which allows for, just like within a normal spacer, extra space to allow for those larger particles and so that the smaller particles can go deeper into the lungs. But this can spread out, and then these little clippies, they clip together so that we don't have all this extra dead space, and so it like lays nice. It's lovely. Also, these little white caps, there's multiple layers of it that you can open and close that allow for different sized MDI. So you can take the MDI out of the boot, and if there's like the different medications sometimes have different ports, and this has different shapes for the different medication ports, so you can flip and have the different sizes for the different ones. It's lovely. They're new, they're beautiful. And so then you can find what little port fits your medication that you're giving, whether it be a bronchodilator or an inhaled corticosteroid. Most of the time I've given inhaled corticosteroids through inline MDIs. So like a Pulmicort or Symbicort or a Dulera, something like that. You will have to take it out of the boot, the little boot thing, and then try your best to time it with your patient. But overall, it's going to be within the sealed system, so it'll get to your patient eventually. But that's inline MDI spacer. That's one of the things we'll have you guys practice. It's kind of nice. And then after you open it up and administer it, you just close this back up. That way we can just put it in once, and then we don't have to keep opening and closing our circuit, and it just stays in line. See, this end goes at the Y, and this connects to your circuit, and then we can just keep our circuit closed. It's great. I love it. We also have our inline SVN here. This is what's called a spring T adapter. This also can go inline on the inhalation limb. So by the Y. So what this is there's literally a little spring here, and it closes. So you take this cap off, and you can literally push up, and there's some, and I want you guys to like play with it, like literally put your finger in it. It has a little spring. Take the spring and push up, and it will lift this little piece up and open up so that it open up right here and introduce a flow, so you can kind of introduce into here, so that the medication, you nebulize your SVN. So you take the neb cup, and it fits right in here, so you can nebulize your medication into the ventilator, and then when you take it out, it will close it. It's really nice. You nebulize at 7 liters. Don't perform your ventilator check while you are running it, because the extra flow will mess up your volumes. But it nebulizes pretty fast. So a lot of times, if I have a medication I have to give by an SVN, which on the next slide I'll kind of talk about that. I love the Aerogen, which we'll talk about. It's the most beautiful thing on the planet. But if you have a more like thick or more caustic medication you're administering, you might have to deliver it by an SVN. A lot of times while I'm nebulizing it, that's when I'll like wipe down my ventilator and futz around, make my room look nice, make sure all my circuit looks good, make sure all my heater wires look nice, triple check that my patient looks nice, and my emergency equipment's good to go if I need it. Just basically all my pre-shift, my first shift things I'll check while that's nebulizing, because it doesn't take very long. It only takes a couple minutes, but take that it's kind of like your 3 or 4 minutes to take the first of your shift to check those things, such as, does my patient look nice? Triple check your tube. Um, work from the patient back to perform your assessment to make sure that tube's in the right place. It's not pulling, because otherwise it's gonna pull in their throat and that's gonna be uncomfortable. That your tubing looks nice. Everything's clean, tidy, all while that nebulizes, and then you can perform your vent check at the end after everything's said and done. Okay. And then you can take it out of line, close it. Another thing is just this can kind of turn. Make sure it's upright, because if it's sideways or anything, that med can just dump into the circuit, and then the patient won't get any of the medication. I've seen that happen too. This is the Aerogen. This is an ultrasonic nebulizer. So it was placed on the dry side of the heater. So you'll have so this is coming from the ventilator. So this is the dry side. And then this will be wet in here, and then the water in here, and then this goes to the patient. So that's why it's the dry side of the heater. So dry and then out to the patient. There's this little T-piece, and then the nebulizer cup. You'll either have this that's feeding the neb cup if you need it, or this little thing will be closed and you can just squirt your medication in the cup. Then you have this little controller box, and you can either push the button and it'll run for a few minutes, or you can do continuous, either one. And it will just have this little mesh that vibrates, and it will nebulize the medication, and then it will go through here, down across the heater, and back to the patient. And it is the most beautiful thing on the planet. I love it. And it makes a fine mist, so it goes deeper into your patient's lungs. You can't give some medications through it, but that's okay, because it's only a couple medications we don't give very often. So we'll forgive you, Aerogen, for all the beautiful things you've done in this world. But yeah, you can do both continuous and intermittent medication delivery through Aerogen. So these are the three main ways we deliver medication. We can instill some medications directly down the ET tube, but it's not very often. I've only done it like once or twice in my career. So, well, besides surfactant administration, but that's a story for another day and another lab. You'll learn that in 3260. But in an adult, it's very, very, very rare we instill medication down the ET tube. So, but these ones you'll do all the time. These three. So get real comfortable with it. You're gonna get very comfortable, especially this guy. This is your new best friend. So. These are just some considerations with medications. Caustic medications can ruin the internal workings of the ventilator. So on the expiratory limb, right before it enters into the ventilator, if you might need to place certain filters. So HEPA filters or DAR filters might need to be put in place on the expiratory limb. So some of these medications might be hypertonic of any percentage, if that is ordered for your patient, mucomist or acetylcysteine, you might also hear that called. Any type of antibiotic, so if you have a cystic fibrosis patient and they order something like tobramycin, these can get into the ventilator and ruin the internal workings. Flolan, which treats pulmonary hypertension. You'll also hear it called epoprostenol. These can get in. So just if you're ever wondering, throw a filter in line if it's going to mess up your vent. That way it's not going to hurt your vent. Also, some of these, such as hypertonic and mucomist, they can't go into the Aerogen, and you'll learn it as you go. Like, this isn't you have to commit this to memory. It's just kind of a be aware. And you'll learn like your policies and protocols when you guys start working. So again, this is a just be aware that it's better to nebulize it through the SVN than to put it through the Aerogen. So, but again, you'll learn that when you guys start working because different hospitals have different protocols for different meds. But medication types. First, you give your bronchodilators, then you'll, whether it be nebulized or an MDI, then you'll give your mucolytics, whether this be Eucomist or hypertonic, and that's because these can initiate or cause bronchospasms. So that's why we want to pre-treat any type of mucolytic, so whether it be hypertonic or mucomist or anything like that, is because we want to prevent any type of bronchospasm. And then after that, we will give an inhaled corticosteroid that normally is given twice a day. Okay, I promise I'm done. 2 more slides. Okay, alarms. So, in your Lindsay Jones book, there are 3 alarms for you guys to know. And they're a little bit vague. So the alarms are based off of your values you're getting off the ventilator. So your high pressure alarms are 10 to 15 above the baseline of your peak pressure. So they want you to know the peak pressure you're getting off the ventilator and then go 10 to 15 above that. Your low pressure alarm, they want to know your peak pressure alarm, your baseline peak pressure, and then go 10 centimeters below that. Which, in a real life vent, we don't have a low pressure alarm, we just have disconnect alarms. And then a low tidal volume alarm, they want you to set 100 mLs below your set tidal volume. So just memorize those for your exams. In the real world, these are just guesses. You guys will find what's working for you. Well, not really guesses, but this is commonly what I've seen in the different hospitals I've been in as a student, but also like the 2 hospitals I've worked in. These are kind of where everyone kind of set them at. High rate around 40, and same with high pressure. And the reason we set the pressure a little bit higher, around 40, is because if you have a patient that wants to cough, that we can let them cough, but then it not be like alarm, 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 alarm. But if your peak pressures are reaching close to 30 centimeters water pressure, that's when I want your, so high 20s and reaching up to 30, that's kind of when I want your warning bells to start going off on your feedback for your patient. So if you're like, okay, my peak pressures were in the like low 20s, but now I'm like, my peak pressures have been like 22, but now all of a sudden I'm like 28, like what's going on? That's kind of when I want warning bells to start going off. Your tidal volume alarm, around 2 to 3 times above and below. Your minute volume, 3 to 20 liters, and then we don't have a low pressure alarm, we just have a disconnect alarm, which normally is around 20 seconds. So those are alarms. Because also another thing we'll do is while we're setting up an event, like if we get a call, this is clinical practice, if we get a call that we're getting a patient, they're like, oh, hey, we're getting a patient from an outside hospital. They probably won't be here for a couple hours, but I'll just set up the ventilator for a few hours away. That way I can just have it ready to go. I'll put my alarms in ahead of time. That way I don't have to deal with it. So there's that. All right, last slide. We're going to talk about a little bit about sensitivity. Sensitivity is essentially how, again, I know this is going to sound redundant. It's how sensitive the ventilator is to the patient triggering the ventilator for a mechanical breath. So how much effort the patient needs to put in to tell the ventilator it wants a mechanical breath. So this is for control modes. So this is for whether we are in assist control or SIMV. So we're in either assist control or SIMV, we're chugging along, and then our patient triggers that they want a breath. This is our patient trigger. This is our negative inflection of our diaphragm. Our drop in our diaphragm. When we set our sensitivity, so if you see this little V dot, that means flow. So we either will set this in flow or pressure settings. I'm going to go ahead and say 85% of the time you are going to set this in flow. Most of the time, pressure patients that I've set it in pressure are patients that are extremely hard to ventilate and have been on the ventilator for a really long time, and we have to start doing some funky stuff. Most of the time, 2 liters of flow for about 85% of patients is most comfortable. But the range is between 1 and 5. So essentially, 2 liters of flow, boop, of drop. So two little drops in the flow here, bloop, just like a 2-liter nasal cannula for this patient to drop to say, I would like a breath, please, bloop, for them to get a breath. The less the number, the more sensitive. So if I have a weak little itty bitty grandma that had a little procedure and she's just having a hard time triggering the ventilator, I'd go more of the 1-2 range. But if I had a big giant D1 football player that was showing my vent who's boss, I might go more the 3, 4, 5 range because they have a bigger diaphragm and are a lot stronger. So the higher the number, the less sensitive. The lower the number, the more sensitive. And that's because it's less flow or pressure that patient needs to trigger. So it, like, that football player would need like 4 of flow to drop their diaphragm to trigger, where the grandma would need like 1 of flow to drop their diaphragm to trigger. Flow is more sensitive than pressure. That's also why most of the time we put our patients in a flow sensitivity trigger than a pressure. Again, it's a lot of the times our pressure sensitive patients are like our long-term trach going home with a trilogy hot mess patients. Most routine patients are comfortable with a flow sensitivity trigger. So kind of play around with that when you guys get on the ventilators. I think an hour of me is enough. Please let me know if you guys have any other questions or anything like that. Sorry I won't be there Thursday, but let me know if you guys need anything or have any other questions. I am available. Okay. I will post this to YouTube if you guys have anything else you need. Okay. Thanks, guys. Artie says hi also. Bye.